log into Genicon.
Okay. Whatever you're showing off.
Yeah. I realized last night because I had like obviously written everything down. This is also my board setting, so it's like right in the middle of my board. I had written down the page. I was like, oh, I don't need this anymore. I already talked to it.
Recording in progress.
Hey, everybody, can you hear us at all? Hello. Yep.
Hello.
How about that? Sorry, can you hear us okay?
A little choppy, but
Israel, Scott. Looks like you're there too, huh? Okay. So you're good? A thumbs up on your side?
hello. Can you hear me?
Yeah, we can hear you good, Israel. How about Scott? Can you hear us? All right.
I can hear you. It's a little bit.
Sounds great. Well, thanks y'all for coming together. I know Jonathan might try to be able to make it today. We'll see if he pops on. I also invited Dr. Henna to join us, but I know she's still in the midst of some traveling stuff, so this might be our crew today. So excited y'all came together. And we talked about a few things today, and I thought I'd give Dori the reins here first. We're going to have her share a little presentation. Thought we'd have asked him for a few minutes to just share a few of his bag of tricks with us today about patient care. And then I really just wanted to just touch base with you on a new improvement and adjustment to one of our current policies, discuss that, and then got a few, I guess, things to discuss. So anyway, we'll let Dori kind of take it away. And as far as sharing the screen here, let's see. This right here? Okay, I'll let Dori take over where she's going to be sharing her screen here. Okay. There we go.
Can everyone see the Genicon screen?
Yep.
Okay, perfect. So this is a patient I had in Cibolo maybe a couple of weeks ago. It was a 19-month-old female coming in for their new patient visit the first time. Mom and dad had just recently moved from another state, so they haven't really established care in the area, and this is kind of their first visit. They said the daughter had one other dental visit around 6 months of age where they were living before, but otherwise kind of first visit for her in general. For medical history, it was pretty insignificant. No medical history, no premature birth, no complications. For hygiene, they were brushing one time a day at night, doing mainly water during the day, and very rare occasional juice. So had good habits. Everything was good. Upon the extraoral exam, the only thing to kind of note for the child, she was pretty tall for her age. Both parents were also tall, so it makes sense. It all added up. When I went in for the oral exam, she had 8 of her front teeth present, and then her 2 upper molars were starting to come through. She did have a little bit of a thicker frenum, but the parents came in with the chief complaint that day of she has crooked teeth. So, you know, at first, a lot of times parents just, those 2 incisors come through, they're a little crooked and they worry about it. So I'm like, oh, no big deal. Well, I go and look, and this is what she presented like as far as her crooked teeth that day. So that was the presentation. So yeah, you can see very abnormally shaped teeth. The teeth on the mandible actually look completely normal, good spacing. The molars didn't present with anything really significant. It was just 4 maxillary anterior teeth, very conical in shape, very long in shape. So after I did the exam, the first thing I said was, let's go ahead and take an x-ray just to rule out some things. We know that sometimes supernumerary teeth can be abnormally shaped. And I also wanted to rule out any like enamel or dental dentin defects. So went ahead and took an x-ray with the child. This is how the x-ray came back. As you can see, no extra teeth, no missing teeth. Everything is accounted for there. Enamel, fairly blurry x-ray, but enamel didn't pulp all look pretty normal and ratio here. So we kind of were able to rule all of that out. So the next thing we kind of jumped to with the parents was likely this is something syndromic that we'll kind of think on. And at the time I had what I thought was likely the case, but I also know that there's a lot of other things that it could possibly be. So I just told the parents, I have a good idea of what I think it is, but just give me a little bit of time. Let me do a little bit of research. I'll come back, I'll call you tomorrow, and we'll kind of go through the next steps. So sat down, kind of thought of just maybe 3 or 4 differentials. At the top of my list was the ectodermal dysplasia. The next thing was I don't even know how to say it, incontinentia pigmenti, which is, we'll have that same conical shape. We'll also have missing teeth, but the main thing about that one is there's usually a rash present at birth. And of course, sometimes parents just don't mention things on medical history, so still kind of left that in there as a possibility. Something else that kind of popped to my mind was the chondroectodermal dysplasia. Sometimes that can be seen with heart defects, and it also, most of the time the kids are shorter and they have really short limbs, and they have to use growth hormones and things like that. So just off base seeing the child, I kind of ruled that one out. I did ask the mom though, when they went to the pediatrician, did they ever mention that they're low on the growth chart or have anything, just making sure I wasn't going crazy, and no, not any chance. They were always 99th percentile for growth. And then the last thing that I considered was like Apert syndrome or Cruzan syndrome. But with those, typically there's pretty significant medical history, pretty significant facial deformities. So I felt like we were able to rule out that as well. After asking mom about the rash at birth, she said, no rashes, nothing happened. So we kind of went back and decided to stick with our first differential diagnosis of the ectodermal dysplasia. No other medical history, because sometimes ectodermal dysplasia can also affect teeth, hair, nails, skin, things like that. Mom didn't have any other things that she really noticed for her, but she's also not set up with a pediatrician. So during the call, we kind of got her set up with a pediatrician, did a kind of referral to the pediatrician to go ahead and get blood work and get genetic testing done. That's the way that you would officially diagnose ectodermal dysplasia. And so mom's working through that right now of getting her first pediatrician appointment, getting the blood work done, and going through that. Kind of prepared mom that also likely in the future there's going to be some other additional problems, some missing teeth and things like that. And for management, it's just all aesthetics, so all kind of up to them if we can do crowns or resins or things like that, or just let it be. So yeah, she hasn't totally decided on as far as aesthetics how she wants to correct it, but she's currently in the process of doing the blood work and all of that. And so it'll be interesting to see if any other medical parts or conditions come up when they do that.
Okay. You might click it back over there. Let's look at the intraoral maybe. So after you looked at it, let's say mom wanted to come back and she did want to do something aesthetically with these teeth. Looks like they've got pretty long crown length, but they almost at the same time look like they're almost partially prepped.
Yeah.
for teeth. What challenges would you foresee in trying to be able to prep those teeth? What kind of approach would you do? Or if you said, yep, I want to fix these, what would you do?
So I feel like in order to get the ideal shape and everything that we want, I think doing resins without getting into the pulp would be very challenging to make it an ideal shape. So my kind of thought process is probably over prepping and making the crowns to a more ideal shape, needing to do root canal treatment, and then probably doing PACs is I think the best way to get the most ideal appearance. If we do resins, I think it can happen. They're probably just going to be longer and longer without doing pulse.
Israel or Honest, have you guys had much experience in ectodermal dysplasia and patients, in treating them?
Say that again. You kind of broke up.
If you have any.
A previous experience in dealing with ectodermal dysplasia, I had a couple of patients, but to be honest, nothing I presented really kind of this early. So, any thoughts y'all have?
So I saw something similar in this DC, and we never got the test back. The patients never really came back to really confirm. But I think looking at this case, my only concern would be if you look at E and you look at the kind of like how high like the cervical region goes, getting a crown on there would probably present with some type of difficulty, unless again you kind of over prep and try to get the crown to go really far into the gingiva. And so my thought would be for something like E, maybe doing some like resin would probably be better, but again, I could be wrong. So, but just looking at it, I would feel, to get the crown to seat all the way up there, you see how high the gingiva is, especially on the distal aspect, on that facial. But this is very interesting. I would love a follow up once you get done with everything.
Any chance, Honest, you worked with ectodermal dysplasia at all?
I did. I had like 2 cases, I think, with amelogenesis imperfecta. A little bit different, but like this is where they come completely like yellow, and this is where we did end up. I did case in New Jersey, and then we did a full mouth crowning, and we end up really pulping everything. So at the end of the day, you just don't want to, like, even if you're not sure you're pulping, the problem is sometimes you put it on and the teeth don't like it from the occlusion. So you want to really remove any worries from a pulp issue coming up later. So that's usually, especially with her age now, if you're going to get there, I definitely will. If we want to do crowns, I'm with crowning and doing pulpotomies on those teeth. So we've done a few, and we followed up, and it was everything good. Yes, we run the risk of something going south from the pulp, but you get the risk of something going south is less than the satisfaction of the parents to have really nice straight teeth. So I got it one time from.
After I talked with the mom about everything, I kind of gave her treatment options if she wanted to correct it. And mom and dad were just both like beautiful people, just perfectly straight teeth. I mean, very well manicured, beautiful people. So I assumed that they wanted that for their child. Well, the mom told me, she said, I'm actually a dental assistant. I would really prefer to like not do anything invasive and not have any work on her. So that was really interesting. After
Oh, wow.
and she may change her mind down the road. But,
It's the opposite, right?
yeah.
the scare from healthcare. Yes, we see that too.
Well, thank you, Dori, for sharing that case with me. We'd love to hear you follow up again. For those that's working similar, I guess if they happen to go across the path, we'll have to sort of keep things going there. So, very good. Thank you. Appreciate that. Israel, I want to take a few minutes. I know I kind of put this on you just yesterday to think about, but Israel's been with us for kind of pushing almost a year's time here, getting closer. And, I wanted him to share maybe a little few tricks of he has in his bag of tricks as far as treating patients and maybe speed or what he likes in his hands, and kind of share that with us today. So, Israel, lay it on us. What do you got?
Okay. All right. In terms of prepping for composites, especially on the younger patients, I find that especially if you get good cooperation, and what I kind of try to do to ensure good cooperation is as long as it equals 6 liters per minute, if you do like 60-40 on the nitrous, kind of get the patient nice and comfortable. I let them sit on that for 30 seconds to a minute, tell them that their fingers might start to tingle, their toes might start to tingle, you may feel a little floaty, but don't worry, mommy will catch you before you hit the ceiling. Just don't float too fast, things like that. As long as they're nice and comfortable and you kind of let try to manage the expectations, tell them there's gonna be some cold air and some cold water. You feel anything other than that, just raise your hand. I'll stop, I'll give you a break, I promise. And and a brand new 330 burr, especially if you look in the burr block and kind of like the neck of the 330 is super black, it'll be like a rough prep. So if you 9 times out of 10, if you use a brand new burr on a high speed, you can pretty much prep even like a class 2 without any anesthesia. And I think um, sometimes when you go to give anesthesia, you may lose the child a little bit, and it may take you a little bit longer to do things. But again, you manage expectations. You tell them cold air, cold water. I'm just going to tickle these sugar bugs out of your teeth. They kind of are already prepped for that sensation, and I find that I get through restorative preps a lot quicker that way, especially with a brand new bird. It's like cutting into butter, and as long as on the X-ray, as long as it's not too deep, even if you're cutting into dentin, a lot of times the kids do all right with that, and that for me has been my saving grace over the years. I remember my professor in residency told me that, and ever since then I took it and I ran with it, and it's been a godsend in terms of speed and getting a lot of things done at a quicker pace. And then also parents appreciate it too. They're like, "Oh man, that was quicker than I thought it would be," and I was like, "Well, I figure you wouldn't want to be here all day, so I just don't forget that I hooked you up, all right?" And then they're cool, and so interesting. Sorry, I know I'm taking a little bit more time than allotted to me, but interestingly enough, I had a case come back today, a follow-up post-op sensitivity from when they had the filling done in April, and I don't think we had the Permaseal available at the time. And so a lot of times when you go to finish the restoration, go to polish, they develop, these micro cracks, and the patient was complaining about sensitivity. So I etched the tooth real good today, especially around the prep. And then I sealed it. And then I ended up sealing the rest of the tooth with the Permaseal and did air, water, cold water tests. Patient was perfect. So I add that now to every restoration when I'm done. And I think since then, so this was before I think we had the Permaseal adopted in all the offices, but since then, I haven't had any issues with sensitivity with restorations post-op. I haven't heard anything come back. So I think these tools are pretty good to ensure successful restoration and limit post-op sensitivity, but also again the kids appreciate too not having to be numb for half of the day, and they can just go on about their day without feeling like their lip is going to fall off or feeling like their cheek is super fat. But that's helped me with the speed considerably. So
Thanks, Israel. I want a follow-up question. What when you're doing your class 2s and approximate, what matrix do you prefer? What do you like to use between the teeth?
So so at first I was using the fender wedges when I started here, and for some of them the contact space is so tight, and I always get a lot of bleeding. But the auto matrix has been a godsend for me. I see here they have like smaller ones, for the baby teeth, which is
We got them from Dr. Scott.
Ah.
This is the
Yeah.
like we're almost out.
those are perfect, but I use the Automatrix. Ever since Dr. Scott showed me how to use it, one of my first days there, it's been my thing. So I've been very successful with using those. A lot less bleeding, and then sometimes depending on the shape of the tooth and how much you prep, because I start off with a box prep. That's one thing too. Proximal box prep. If it gets much bigger than that, then I'll switch to more traditional. But 9 times out of 10, you're knocking the caries out with a box prep. You get a pretty good shape, and you might not even have to use a wedge when using the Automatrix, and you still get a pretty nice restoration at the end. So
Very cool.
with
I was just with you, and that answers my question perfectly. Fantastic. So, and I agree with you. I've been using the PermaSeal a little bit more. Of course, I've always been one that sealed over my restorations anyway, but especially I love that PermaSeal is fantastic on the anterior restorations that I've done. And,
yes,
and really, kind of shining them up and sealing some of those little tight areas are hard to get to. So love that. It's great.
Yeah, it's been awesome.
Anybody else?
So regarding the Automatrix, like, are we thinking to adopt it as the pedo one instead of other things? So that's might be another thing we can discuss, because I used to use the Tafelmeyer before, and I used to cut the adult in half to make it a little bit not that thick, so I can do the pedo one. But then when we got the one from Dr. Scott, the little one, the automated, of course I start using it more.
That's a lot easier.
It is a lot easier, of course, and I think even it's easier than if we receive the pediatric Tafelmeyer, because the pediatric Tafelmeyer, they're good, but our instrument, the Tafelmeyer itself, it's starting to wear off a little bit. So
yeah, I can't disagree. That's actually what I wrote down here. I was like, let's get us some more of these these mini bands,
I like the to use this. I love the Automatrix for the adult teeth.
So yeah, I don't know. I'll have to ask Midwest to talk with Dr. Scott about his order number, and I mean, I think us switching that out for the Tafelmeyer seems like a pretty good idea, and probably also needing to get some more Tafelmeyer tighteners.
The Automatrix tighteners?
The Automatrix tightener to work for it. Yeah, absolutely. So, I'm all into that. Sounds great to me.
I don't know if you use those golden bands before. They looks like a Tafelmeyer.
The T band,
The T golden, like it's a similar thing in the small, so they're quick. So I like those.
All right, well, good stuff. Thank you, Israel. Appreciate you sharing some of those tricks with us and stuff for us all to think about. As part of our doctor conferences, I'm going to probably kind of do a little rotation. I think all of us sharing some of our little tricks that we have are good. Those things we pick up along the way, either from professors or through life experience, are always really good. So I like hearing that kind of stuff. I'm moving on to the agenda. Last couple of things. First off, I sent everyone just a picture of a hard copy of our rough draft of our new STAR policy. And basically, we're using this as a way to help doctors be aware of how long patients have been waiting for us within the office. And just as a heads up to us, we're still getting it implemented. The staff is still kind of getting used to it and doing it. But one other thing I've been toying with about using this system is allowing us to be able to help each other, especially when there's more than one doctor in the office. We have two teams going simultaneously. We all know there's times where one doctor might be ahead of schedule or on schedule and the other one's falling behind for whatever reason. And we get a moment where there's an imbalance. We have people waiting for to see one doctor, but we have another doctor actually sitting and waiting to see a patient. And it doesn't make any sense to have those two things coexisting. So we tried to pass other ways to kind of communicate that. The managers are deciding when to sort of swap a patient over. But I'd like to toy with the idea of maybe implementing using our STAR system as a way to do this, okay? And so what we're kind of considering doing is once we have two doctors in the office and the STAR goes up for one doctor, and let's say they get backed up, maybe you've got 3 or 4 patients all kind of been waiting for them. If the other doctor doesn't have any patients, they can automatically look up and see doctor number 2 is behind and just automatically go over and see one of those patients. And then they go back to the regular patients, you know, and then if they again catch up and there's another one, they go back over and help. And it's a 1 or 2 patient swap kind of a thing, just to make sure we keep on track and make sure we're keeping our staff or our schedule on track, and are not have to get our staff too involved in the process of a doctor switch happening. So we're going to trial this in Seguin a little bit and see how it kind of goes, see what the kinks kind of are, see how the staff and patients kind of tolerate it, and see if we can figure it out. But it's on the horizon, and see if it works well. So I just want to make sure you were aware of it and kind of knew what you were doing, because it really involves we're really making this decision based upon the doctors being able to kind of work hand in hand with each other. And certainly I don't want there to be a sense of like patients being stolen or us, you know, picking up too much for someone else or anything of those things. Really, it's a chance for us to work together to try and help make the schedule run smoothly. So anyway, that's just on the horizon. We'll let you know how the trial kind of goes, and you know, start seeing how that implementation takes place. Okay, so I want to make sure you're aware of that. 2 last things I've got. There is the TAPD has in September their annual sedation CE course. I'm planning to attend. It's in the middle of September. And anyway, I just thought if anyone else is in need of a CE course and wants to go along, I'd be happy to cover the cost of them to come and join in. So you guys can kind of look at your schedules, look at what might work, if you need the course, anything like that. Would love to have anyone that wants to come along. And you're probably sick of hearing me talk anyway, but we'll get to hear somebody else. My former professor, Dr. Bobby Thickerstein, is teaching the course. He is fantastic. He's the one that taught me how to do sedation. So anyway, he teaches a great course, and I just want to make an open invitation to anyone. Just let me know if that's something you'd like to maybe be interested in attending.
What are the dates for that?
Yeah, September 15th, and it's in Austin. I think it's at a downtown somewhere. I can't remember the exact location. It's a 1-day thing, you know. It's not an overnight, or it's just a 1-day conference type of deal. It's an 8-hour CE. So there you go. I'm happy to send you guys the information if you like.
Quick question. So I just had the sedation course too. Because
can't quite hear you, Honest. Can you talk a little louder? We lost your volume.
Can you see? Can you hear me?
That's a little better.
Okay. Perfect. So I just did the sedation renewal course. To you, I was not sure. Those 8 hours does not count in the 22 or 24 we need in 2 years, right?
So I think I understood your question right. So we have to get CE hours for sedation every single
Dr. Honest,
for a renewal every 2 years.
your microphone is muted. They're picking it up through my headphones.
Oh.
Okay.
See when we're now it's better.
Better, yeah.
I mean, I got a pretty good mic.
So you should be mute too. So my question to you is like this 8 hours. So if I understood it right, the CE 8 hours for the sedation renewal does not count for the 24 that we do every 2 years, correct? Or they do count? I'm just a little bit now confused.
My understanding is they do count. You can count them for your 24, your annual dental renewal or semi-annual dental renewal. You can count those CE courses as well, and it also can count towards your sedation. I've done that for several years, so if I am doing it wrong, I guess I probably need to fix that. But my understanding was that you can use it for both.
And another, because this is what something that the guy said when I renew it, that this is just for the sedation. It should not be with. So I don't know if it's something new or he mistakenly say it. So we should ask about it. And another thing, regarding the pulse too, the pulse renewal course. So I don't know if you need to do it soon as well, but I used to do it online. But then there is now a new part of like hands-on something. So I'm not sure if like I did it. So and I have now the certificates, but I don't know if we need to get a hands-on like a course. Like this is not clear yet too. Did you hear anything about that?
I just renewed and had my online house course, which they accepted. So I've not heard anything more about needing to have a hands-on course. I don't know, Dori, do you?
I did see what Alex was talking about when I was attempting to renew mine. I go to a great class
You recommend
that I would
something?
recommend if you want your PALS and your CPR very quickly with hands-on experience.
Let me get
Well, you mean
that.
Dr.
Yes, I
Dr.
would
David?
for that.
If you can send that information to me, but if I can jump in, you guys know I had my licensing woes for quite some time. For a long time, Texas was playing with me, but the last thing I do remember saying was in your 24 hours, if you're doing sedation, 8 of your hours has to be in the sedation course, so it does count towards your 24 hours.
That's what I thought, but then the instructor like said something in the line of those do not count in your 22 or 24, and I was like, okay, what is right, what is wrong? So I'm gonna like explore more, and if I find it, I will tell you. But that's something came to my mind with the pulse recently, so I was just gonna mention it. So we're not surprised there.
Yeah, and then with my BLS, so this part of what your question may be true. I had a BLS certificate, and they told me I needed to have it from a live class, so I had to redo it. Well, in order to get my actual dental license for Texas, they made me redo it.
Yeah, so you can with the pulse course, the certificates. Sometimes you can get it, sometimes you don't get it, so you have to apply for it. But I just want to pick your mind, guys, because I'm a little bit confused, and I just want some feedback.
On the note of licensing, while we're doing it, did y'all also see any new requirements now for the DEA to get that? You have to do a separate, like 4 8-hour course, something like that. I think you only have to do it one time.
Yeah.
They sent that in the email recently, right?
Yeah.
What can you repeat?
Diversion control or something like that.
Yeah.
Oh,
I guess whenever you renew your DEA, they may ping you for
right now
for that. So there you go. That's I think it's every 3 years, is it not?
For your DEA license. They're making you take like a course, but you only have to do it one time.
Okay, so I have to renew my DEA anyway this year too. Everything is coming up this year.
Lots of stress. Well, open invitation then for the CE course in September. I would like to, and then I would like it to be fun at some point to really have like a group CE of some kind that we all get to go do together. I'm kind of thinking of a few different things. There is one kind of a weekend course in Las Vegas in February. That's kind of a cool one. So a couple thoughts on it. I think it'd be fun as a doctor team to go and do something like that. It would be like a 2-day deal or something. So anyway, I'll keep you apprised of that and see if that might work out. It'd be fun.
Please get me out of the kids a little bit.
Yeah, that'll be fun. I've never been to Vegas, so.
Well, hey, there we go. That'd be fun. Last thing is, I am teaching my annual residence. I teach my residence seminar various places, but I've got my annual one that I teach at the Health Science or for the Health Science Center in San Antonio at the Civil office on the 18th. So anyone that wants to come here, practice management stuff, they're welcome to come. It'll be from like 9 to 3 that day. Some of you have heard it because you actually attended as a student, which is kind of embarrassing. But anyway, that's an open invite too. No obligation, of course. But
the 18th next month.
Yeah, it's on the 11th of August in Cibolo. It'll be at the Cibolo office. Okay, they drive over from the program, and I do it there.
Yeah.
Well, that's everything I got, Scott. We didn't give you much chance to speak today. You were here just last week. Everything okay in Utah?
Your microphone is muted.
It is. Everything's good.
Good. Looks like you're there. You're in the basement of the office.
Yeah, and I sent you the part number for the narrow automatrix band, and also a couple of things off the Texas Board of Dentistry website about CE. So hopefully that helps.
Well, Scott is thankfully our kind of our in-house resident, state licensing, credentialing, and organized dentistry expert. So,
where were you when I needed you in October?
Yeah, I know. But last Friday, I was voted clinic manager, right, Dr. Dori? On Friday, yeah, late afternoon or late morning, I was voted to be for the temporary, clinic manager.
That's a good promotion.
It's totally based on seniority, and Anyway, no, I appreciate learning. I kind of agree with what you talked about with Dr. Dori's case. That to me, it's either most you'd ever do is minimally is just maybe round off some sharp points, or otherwise you've got to. I would be inclined to even do an impression and prep the teeth on a model, and so you kind of know going in what you're going to what your reductions are going to be, even reduction coping, so you know right off if you're just doing like 4 anterior teeth, you'd know what you're going to deal as far as pulp stuff. So anyway, that's the way we do it with big people's dentistry sometimes. It's those reduction copings.
We forgot about this stuff.
Hey, well, thanks everybody. You guys have a great rest of the day, and look forward.
And someday robotics are going to prep teeth, and then you're just gonna the tooth will be prepped to fit the crown. Yeah, it's there in orthopedics. It's coming to dentistry.
Okay, everybody.
A lot of things are coming to dentistry. Have a good one, guys.
Thanks, you guys.
Bye.